So this is a topic very dear to my heart because I really think that can actually improve your breast imaging. So, and I will run briefly through all the steps that are what actually is multi-parametric MRI. So, and in all fairness, we always have been multi-parametric because as long as you have T2 and DCE, that are already 2 parameters. But so again, MRI, in particular dynamic contrast enhanced MRI, is the method with the highest sensitivity. Again, we have our specificity ranging on study is variable. Again, this is something I will say, I think most likely in every single presentation. It has not a limited specificity. It has a good specificity, but it's not limited as prior publications which reported 37% specificity. Well, this is 20 years back. We have improved. However, we still have to note we have false positives with a PPV of 35%. So we're doing actually a lot of unnecessary biopsies in benign breast tumors. And so the idea, what can we do to make this better? Well, there have been, which I have talked before, we have talked about increasing the resolution of our dynamic contrast enhanced scan to give us better appreciation of lesion morphology and enhancement kinetics within over the time course. And this concept has worked well. We have improved ourselves because higher resolution appreciate morphology better. But then we have still lesions like that. Here we have a partially irregular, rapid plateau enhancing lesion. What are you going to do with that? Are you recommending biopsy? Yes, obviously you will, because there is no other parameter that can sort of bail you out. A T2 signal intensity will also don't really mean anything here, because I mean, even if it's hyperintense on T2, I have seen so many hyperintense T2 hyperintense cancers in my lifetime that I will never ever base my decision to downgrade a lesion just on that. So this sparked the concept, can we add more? So mainly our interpretation is currently based on assessment of morphology with a little bit of functional information from the kinetics. But in kinetics, we know there is an overlap between benign and malignant lesions. And this is where the concept of multi-parametric imaging came into. And so obviously when you have more than 2 parameters, we can call it multi. And this is, at the beginning, they merged spectroscopy and diffusion-weighted imaging. They came out at the same time, and I think in the beginning, spectroscopy was more the thing that was felt to be of value. There were lots of publications suggesting that it has a value. Diffusion-weighted imaging in the beginning had the problem, basically, that the images didn't look like that, which I'm showing you here in the corner for DWI, but rather you were actually wondering what organ has been imaged because of the distortions that were there. However,